All right, welcome back to another Explainer. Today, we're jumping into what honestly feels like a high-stakes medical detective case. We are going to decode one of the most widely misunderstood concepts in cardiovascular medicine. I really want you to look at this not just as a clinical review, but as a puzzle, where jumping to the wrong conclusion can literally mean the difference between life and death for the patient sitting right in front of you.
Okay, let's dive into this. Picture this. You've got two patients sitting in your clinic. Both of them, totally by chance, have a mean pulmonary artery pressure of exactly 35 millimeters of mercury. The exact same number. The definition of pulmonary hypertension is completely satisfied for both, but here is the massive paradox. Patient A has a rare primary disease of the small pulmonary arteries themselves. Without highly specific therapy, this condition is going to be fatal within a few years. Patient B, on the flip side, just has ordinary left heart failure. That elevated 35 millimeters of mercury, it's simply a downstream echo of a completely different problem. Treating your pulmonary pressure directly, that would be absolutely pointless, maybe even actively harmful. It just goes to show something fundamental. Pulmonary hypertension is a finding, right? Not a disease.
So let's look at the actual numbers here to ground our investigation. Officially, pulmonary hypertension is defined as a mean pulmonary arterial pressure of 25 millimeters of mercury or higher at rest. And crucially, that's got to be measured by a right heart catheterization, that invasive, non-negotiable gold standard for a definitive diagnosis. But like we just saw with our two patients, that single number of 25 or higher, it tells us absolutely nothing about the why. And in this field, the why is literally everything. It dictates completely different diagnostic tests, totally different drugs, and wildly different prognoses.
So, to figure out that why, we need to meet our suspects. Let's look at Section 1, the 5 suspects, also known as the WHO classification.
And this brilliantly illustrates how we map them out. We're not just memorizing a list here, we're organizing them by their actual mechanical source. Group 1, that's PAH, pulmonary arterial hypertension. This is a primary disease right in the small arterioles. Think structural vascular remodeling. Group 2, left heart disease. This is by far the most common cause. The left heart fails and boom, pressure transmits backward into the lungs. Group 3 is driven by lung disease or chronic hypoxia, like COPD, which basically squeezes those vessels tight. Then Group 4 is CTEPH, chronic thromboembolic pulmonary hypertension. This is an actual physical roadblock in the pipes from unresolved clots. And finally, Group 5 is our catch-all for the weird stuff, multifactorial or unclear mechanisms, like certain blood disorders. So upstream, downstream, or blocked from the inside, that's how you organize these suspects in your head.
Now you might be wondering, does the specific group really matter if the pressure is high regardless? Yeah, absolutely crucial. The stakes are incredibly high here. The highly targeted therapies we have, like endothelin antagonists or phosphodiesterase inhibitors, they're built entirely around Group 1 pathophysiology. If you reflexively take those Group 1 drugs and give them to a Group 2 patient whose real problem is a failing left heart, you offer no benefit. Worse, you can actively harm them by making their pulmonary congestion even worse. So treating reflexively without identifying the true group isn't just academic pedantry, it can literally be deadly.
Knowing those stakes, how do we actually start hunting for these clues in the clinic? Let's get into Section 2, the Diagnostic Hunt, starting right at the bedside. Now, what's really interesting about this is how we read the jugular venous pressure, or JVP. It's one of the most critical, yet frequently confused bedside skills. Since the right internal jugular vein is basically a valveless pipe straight down to the superior vena cava, it's an amazing external window into right atrial pressure. But, and this is a big but, you have to be able to tell it apart from arterial pulses. Venous pulsations give you that classic double wave, the A and V waves. You see them way better than you feel them, they completely disappear if you press lightly, and they characteristically drop when you breathe in. Arterial pulses, they're a single wave, punchy, you can easily feel them, and they stubbornly ignore light pressure and your breathing. Well, okay, except for Kussmaul's sign, where the JVP paradoxically shoots up on inspiration, but that's a whole different story for conditions like constrictive pericarditis.
But beyond reading the JVP perfectly, we are really looking for a whole constellation of right heart strain. You'll see that markedly elevated JVP, often with a prominent V wave if the right ventricle is dilated and cause tricuspid regurgitation. You'll definitely feel a parasternal heave. You might hear a super loud, sometimes even palpable P2, as that pulmonary valve just slams shut against high resistance. And as things progress, you'll see peripheral edema and a tender, pulsatile liver. But here's the massive catch. These signs look identical across all 5 groups. The bedside screams that the right heart is failing, but it doesn't whisper a single word about the why. That is exactly why we need a rigorous, systematic workup.
So, how do we confidently nail down our culprit? Let's trace the sequence in Section 3, the workup, hunting the mechanism.
This investigation is essentially a giant systematic process of elimination. Step 1 is the echocardiogram. We use this to non-invasively estimate the pressure and, crucially, to screen out Group 2 left heart disease. You'd also throw in some chest imaging and pulmonary function tests at this stage to screen out Group 3 lung disease. Then, Step 2 is the VQ scan. Let me be 100% explicit here. This is mandatory. Believe it or not, a VQ scan is actually more sensitive than a CT pulmonary angiogram when it comes to catching the chronic web-like clots of Group 4 CTEPH, so do not skip it. Finally, once you've reasonably weeded out Groups 2, 3, 4, and 5, you get to Step 3, the right heart cath. This not only definitively confirms the diagnosis, but it lets you do vasoreactivity testing. That's huge because it identifies a tiny subset of Group 1 patients who might actually respond beautifully to basic calcium channel blockers.
Okay, so we've hunted down the mechanism and confirmed the group. Now, how do we fight back? Let's check out Section 4, stratification and the modern arsenal.
The way we treat this has completely transformed just in the last few years. The 2022 ESC/ERS guidelines basically threw out the old playbook. We used to start with one drug, wait around to see if the patient deteriorated, and then maybe add another, sequential monotherapy. Yeah, no more. Today, management is heavily organized around aggressive risk stratification. We calculate mortality risk using functional class, walk distance, lab markers, the whole shebang. For intermediate and high-risk patients, the new standard is hitting them hard and early with initial combination therapy, targeting multiple molecular pathways right out of the gate. The explicit goal here is to drive them into a low-risk status and keep them there, reassessing obsessively at every single follow-up visit.
And honestly, the tools we have to achieve that goal have never been better. I am so pumped to highlight a massive, genuinely game-changing breakthrough from 2024, the approval of CTEPH. Older drug classes basically just forced the blood vessels to relax. Simple vasodilation to lower pressure, right? CTEPH is a completely different beast. It represents a brand new fourth therapeutic pathway. It's an activin signaling pathway fusion protein. And why that matters is because it actually attacks the structural root of the disease. It rebalances the signals in the pulmonary vascular wall to directly target and reverse the underlying vascular remodeling process itself. It doesn't just manage the downstream pressure, it heals the pipes. It is a phenomenal leap forward in addressing the true pathophysiology of Group 1 PAH.
Of course, beyond medical therapy, we've got some serious surgical options depending on the group and severity. You've got balloon atrial septostomy acting as a palliative bridge to just take some pressure off that right heart, and heart-lung transplant for end-stage cases. But I really want to place a massive emphasis on this last point, pulmonary endarterectomy. If you have appropriately selected patients in Group 4 with CTEPH, going in surgically and stripping out that chronic thromboembolic material isn't just a treatment, it offers a genuine outright cure. Think about that. Which just proves, yet again, exactly why our whole rigorous diagnostic hunt to find the specific WHO group is so absolutely vital. If you miss Group 4, you literally miss a potential cure.
So, what does this all mean? The absolute biggest takeaway is this. The next time an echo report crosses your desk and says pulmonary hypertension, resist the urge to treat it as a final diagnosis. That 25 millimeters of mercury is just the opening scene of the story. It is a finding, not an answer. The real work, the life-saving work, is putting on your detective hat and decoding exactly which of those 5 distinct pathways put that number on the page in the first place. Ultimately, when you see that number 25, you've got to ask yourself, am I treating a number or am I actually treating a disease? I really hope this framework helps you crack the case next time you're out there on the wards. If you found this breakdown helpful, go ahead and hit that like button. Drop a comment below with your questions or tell us what complex topics you'd love to see us untangle next. And of course, make sure to subscribe so you never miss another explainer. Keep learning, keep questioning, and I'll see you in the next one.